Hi, everyone. Thank you for listening. I'm Naveena, a PhD student at the University of Washington. I'm presenting our paper on health information quality and social media in India. I co-authored this paper with Richard Anderson. There's been a proliferation of information related to health and well-being on social media. Recent conversations have increasingly centered on the intersection of health information and political and cultural contexts, and how they must be understood in relation to one another. For example, we see the rise of conspiracy theories or hostility towards public health guidelines in light of mistrust in government institutions or scientific elites. So, as social media platforms are adopted across the world, we must understand the issue of information quality by accounting for varying health systems and beliefs around health, levels of institutional capture and reinforcement of misinformation, and uptake of smartphones and mobile internet. Our paper contributes to this conversation by asking, how do people assess, use, and share health information on social media in rural and urban contexts in South India? In this context, plural systems of health coexist with prevalence of both allopathic and traditional medicine and integration into public health systems. There is also increasing access to online spaces, but with diverse literacies and varying levels of safety for marginalized identities, including women. There has also been increasingly divisive ethno-nationalist politics, with the current government utilizing numerous tactics to promote a Hindu nation-state. A tactic relevant to this work is promoting Ayurveda in particular, a traditional medicine system rooted in Hinduism. To present our findings and discussion, we utilize the lens of tools for conviviality as proposed by Ivan Illich. In his critique of modern tools and institutions such as healthcare, he argues that they have become overly specialized and profit-oriented, in detriment to people's ability to care for themselves and one another. He proposed convivial tools as those that support autonomous and creative intercourse among persons, in contrast to tools that seek to coerce, control, or induce dependency. We thus use this lens to unpack participants' personal goals when navigating health information, versus the impositional values of health misinformation and information sharing practices that they encountered. To answer our research question, we conducted 28 semi-structured interviews over phone with participants across urban and rural locations in the South Indian states of Andhra Pradesh and Telangana. Participants ranged from low to middle income and had a range of occupations, including community health workers, who were integral to information flows in the rural context. All participants were Hindu, and this shaped the health systems and beliefs that they subscribed to. We also analyzed a total of 20 posts related to health that participants had recently encountered. Now I'll provide a brief summary of our findings, starting with what participants felt that they got out of health information on social media. Through posts about home remedies or healthy lifestyle changes, participants found accessible and familiar forms of care to supplement knowledge and material gaps during the start of the COVID-19 pandemic. For example, home remedies were made with easily found ingredients, and posts about boosting immunity at the start of the pandemic were more accessible than other advice, such as procuring masks, given the lack of availability in the village. In their information sharing practices, participants aimed to share useful and credible information while being sensitive to diverse health practices. For example, some participants avoided sharing overtly religious posts about Ayurvedic remedies in large group chats so as to not impose upon people who practice different religions. We also discussed the role of community health workers and social media content creation by locals in supporting awareness of public health guidelines and sense-making within the rural context. At the same time, there were numerous instances where misinformation or information sharing practices served to commodify or discipline care. In comparison to posts that suggested home remedies as complementary to public health guidelines, other posts lionized home remedies as COVID-19 cures. Other content commodified Ayurveda or marketed unverified health products directly to consumers. We also found that Ashas needed to confront impacts of disinformation circulating heavily at the start of the pandemic about Muslims as purposeful spreaders of COVID-19. This required them to balance addressing misinformation with carefully navigating community relationships and the precarity of their positions as workers at the bottom of the healthcare hierarchy. We also found that, especially for new smartphone or WhatsApp users, indiscriminately forwarding information was tied to social status as sources of information, inverting information as a means into an end. We found that participants used a number of tactics to respond to misinformation and people who shared it. Participants variously used indirect and direct ways to cast doubt on misinformation, for example, simply questioning where a post was from, or more directly providing counter evidence. We also found that participants used offline spaces to assess or confront misinformation for more meaningful or private conversations. This was in part shaped by gender roles that some women participants discussed, such as R3, who explained that she would likely not directly say anything about misinformation to men in online spaces, preferring women only spaces. Participants also described how learning about media literacy and responsible sharing practices was a social process, with advice from friends, news about the impacts of misinformation, and debates and moderation in group chats being integral to working towards healthier online spaces. Drawing on these findings, we discuss how we can support the ways that social media was a convivial tool, but also how we can address the challenges of misinformation that individual efforts do not entirely resolve. We first discuss what we learned about the changing landscape of online health information as smartphone and mobile internet penetration increases. For example, noting increased local content creation and how this might shape understandings of community health. We also expand understandings of media literacy beyond the individual and notions of veracity, pointing out the ways that literacy is not just about evaluating pieces of information, but about considering its broad impact in everyday lives, depending on positionality, community roles, and meanings of technology adoption. Finally, we draw on Illich's provocation that the concentration of power within tools must be limited in order to support conviviality. Drawing on our findings and examples of health misinformation promoted by the Indian government itself and social media platforms' inaction in addressing health misinformation, we motivate a turn towards alternative models of ownership of social media, community-based methods of moderation in local languages, and addressing critical media literacy and safety of marginalized communities online. Thank you for listening, and if you'd like to get in touch about this paper or collaborations, please reach out.